Now we have Dr. Robert Rosenson. Dr. Robert Rosenson, who is the professor of medicine at Mount Sinai ICANN School of Medicine at Mount Sinai, and is the director of the Lipid Clinic here. I have always introduced him in one single sentence, and that is the best lipidologist I've encountered in my life. So, Bob, grateful for your presentation here. He's heavily awarded best reviewer for Journal of American College of Cardiology year after year, and multiple other awards, being the primary investigator or co-investigator for almost all the trials of the lipid lowering that you are seeing, be it LDL, be it triglycerides, or the LPA. So, Dr. Rosenson, what is new in the management of the lipids in 2023, rethinking the paradigm? Robert Rosenson.
Well, thank you for the invitation to join the conference for multiple years, and it's a great honor. And as Dr. Fuster talked about, LDL cholesterol is pivotal. And what we know is LDL is a surrogate marker of atherosclerosis and a surrogate marker of atherosclerotic cardiovascular events. From large randomized placebo-controlled trials, the lower the LDL cholesterol, the lower the event rate. Even in patients who have coronary PCI, what is the most important predictor of future favorable outcomes? Being placed on a statin and lowering LDL cholesterol. The lower the LDL cholesterol post-PCI, fewer cardiovascular events. It is our responsibility and obligation to implement effective lipid-lowering therapy. But we often have challenges due to adverse reactions, and how are we going to overcome that? We also have obstacles in terms of treatment adherence, but with the expansion of targets, be it antisense oligonucleotides, RNA inhibitors, gene editing, we can take adherence out of the equation and hopefully help more individuals have a happier and healthier life. These are my disclosures, in large part listed for trials that we're involved in through the ICANN School of Medicine, or consulting where I'm giving guidance on the design of trials, or involved as a principal investigator or an executive committee member for these trials. So there's a lot of cholesterol-lowering therapies that are available. Statins, of course, have been most extensively studied, the most extensively studied cholesterol-lowering therapies, 250,000 individuals in randomized placebo-controlled trials. Statins reduce cardiovascular events, improve survival in people at risk for a cardiovascular event, as well as those with established cardiovascular disease. Those trials show that the longer you're on a statin, the lower the cardiovascular event rate. We have data now going out to 30 years that individuals who are on statins during a 5-year placebo-controlled randomization period have a mortality that's reduced by about 98%. But the major obstacle with statins are adverse muscle symptoms. Even though listed on this slide as the most catastrophic event of a statin, which is rhabdomyolysis, myalgia, myopathy, muscle cramps do occur. We have the recent data from the Oxford group that tries to dismiss patients' reports and say that this is more related to going on the internet, being concerned about the statin, not taking the statin, and reporting adverse events. But I don't dismiss my patients' concerns and their symptoms. Recognize what many people don't, if they haven't read that paper in detail, is how did they define an adverse muscle event? Well, you had to have symptoms and an elevation in creatine kinase to at least more than 4 times the upper limits of normal. Not everybody has muscle breakdown who has muscle symptoms. And that's why they're reporting, the Oxford group is reporting very low incident rates of statin myalgia. It all depends on how you define the problem. But when we engage our patients and we're really trying to help them reduce their cardiovascular event rate, help with the quality of life, we need to listen, all right? And we need to sort through those symptoms. We have ezetimibe, which reduces LDL cholesterol through blocking the Niemann-Pick protein in the intestine. It's moderately effective, but it's a useful adjunct. The PCSK9 monoclonal antibodies are more effective for lowering LDL cholesterol. The recently published 2022 American College of Cardiology advisory recommends that if your LDL cholesterol target is more than 25% above the goal, you can use a PCSK9 and skip ezetimibe. But if you need a lesser reduction in LDL cholesterol, you can go to ezetimibe, which is much more cost effective. There are other therapies that are approved for individuals who have two defects in the LDL receptor. There was mipomersen, which is not marketed anymore due to allergic responses. Lomidopide, which is approved for homozygous familial hypercholesterolemia patients, a very difficult drug to take unless your patient is willing to adopt a very strict low saturated fat diet, because otherwise fatty diarrhea will preclude tolerance to that medication. So diet and pharmacotherapy is key regardless of the availability of therapies. It's not one or the other. It's always a healthy lifestyle, low saturated fat diet, and medications. We have bempedoic acid, which inhibits cholesterol biosynthesis at a step before the statins. Inclisiran recently approved. I'll talk about that agent in more detail in our work with evinacumab, a fully human monoclonal antibody directed against angiopoietin-like 3, a new pathway that's emerging, and I will highlight some of that work and share with you just the overview of a trial that I'll be presenting as a late breaker at the American Heart Association meeting. This is a busy slide. I just include it so you can review the paper from Nur Mohammed that appeared in the Journal of the American College of Cardiology. Most of the lipid-lowering therapies work at the liver. Some work at the intestines, such as ezetimibe and bile acid sequestrants. Lomidopide works in both areas. So it's a busy slide, but just talking about the general targets. With some of the new therapies, the antisense oligonucleotides, the RNA inhibitors, the gene editing, which also uses a moiety that targets the liver and decreases gene editing throughout the body, you're also working at the site of the liver. But we'll go through some of these details now. But what I really want to do, which was the charge that Dr. Narula, Dr. Sharma gave me today, is to talk about new advances. When we thought about the human genome, who could have ever predicted that would result in the wealth of these therapies? It is absolutely amazing through the GWAS studies and Mendelian randomization studies, how many pathways that we've been able to identify that are causal for atherosclerotic cardiovascular disease. We have different approaches. We have the human monoclonal antibodies, of which we've got 3 agents that are approved by the FDA. We have the antisense oligonucleotides, which are being evaluated. One, pelacarsen, in a phase 3 clinical outcome study directed against lipoprotein A. And we have the small interfering RNA therapies, of which inclisiran has been approved, and I will discuss that in a moment. And we're going to be getting involved in gene editing in 2023 and 2024, and I'm giving guidance to multiple companies as to how those trials should be designed. And that actually was a charge from Dr. Charney for me to get involved and have Mount Sinai represented in some of the gene editing approaches. And when you think about gene editing, you would say, wow, it's new, who would want to do gene editing? Well, it's amazing in individuals who are taking 5 medications to lower the LDL cholesterol, how they think about the quality of life. And many of our young patients with a very strong family history are focusing on quality of life, and they want a one and done, approach to their risk. But we're going to learn a little bit more about gene editing when the Verve phase 1 data is presented, also at the American Heart Association meeting in 2 weeks. My major focus is going to be on LDL and LDL-like proteins. I'll focus on PCSK9, apolipoprotein A, which is the major protein on lipoprotein A, and angiopoietin-like 3, protein. In this invited review from the Journal of the American College of Cardiology, we highlighted the differences between the monoclonal antibodies directed against PCSK9 versus the small interfering RNAs directed against PCSK9 biosynthesis. The monoclonal antibodies injected subcutaneous bind circulating PCSK9. PCSK9 is a protein that docks to the LDL receptor and destroys it. Normally, the LDL receptor recycles 20 to 40 times. It binds cholesterol and allows our body to get rid of the excess from the calories and that we have, the excess fat that we take in, a very efficient system. But when PCSK9 is present in the circulation, it docks to the LDL receptor and kills it. So if you lower PCSK9, the LDL receptors will have more sustained effect and will be able to remove cholesterol through the normal pathways. That's the major concept. So the monoclonal antibodies are one approach, but if you can inhibit the synthesis of PCSK9 with a targeted approach, such as the sRNAs, you can also decrease PCSK9. And the advantage of the third generation RNA inhibitors is they have a GalNAc moiety, which means that there's a protein on the compound that takes it to the surface of the liver so the whole body's not exposed, and then it gets internalized into the liver. And that's an additional safety feature that wasn't seen with mipomersen, the phase 1 or first stage of development of that therapy. Now, whether there's differences in inhibiting PCSK9 within the cell versus working in the blood compartment remains to be determined. There will never be a comparison study against the two treatments because they're so effective in lowering LDL cholesterol. You'd need hundreds of thousands of individuals to determine a difference. We know the monoclonal antibodies work, but what's new in inclisiran has been studied in Orion 10 and 11. We've been involved in 1, 3, 8, 15. We're involved in multiple other studies with inclisiran over the last 8 to 9 years. In this study of individuals with stable coronary disease, what do you see? You see reductions in LDL cholesterol of 50 to 54%. Highly effective treatment. The therapy is given subcutaneously. 90 days later, the second dose is given, and then it's every 6 months. And I've implemented this processes at Mount Sinai so everybody in the system can get the availability of inclisiran. It's in an epic order. We've worked with the pharmacies. My team is working daily to get people approved for this therapy. You may say, well, where's the outcome data with inclisiran? Well, it's being acquired. The Orion 4 study is conducted by the Oxford group and the TIMI group, and a group from Harvard led by Chris Cannon, BAME research. Individuals with stable atherosclerosis who've had events, they get randomized to either inclisiran subcutaneous or matching placebo and followed for about 4 to 5 years, a trial of 15,000 individuals. But because this study was ongoing during the COVID time, there may be individuals who are lost to follow-up, had interruption of their care. And so the sponsor of that trial, Novartis, is engaged in another trial of which I'm the U.S. National Coordinator, and Dr. Moran is a principal investigator of this trial. It's called Victorian to Prevent, looking at individuals at very high risk with MI, stroke, or symptomatic peripheral arterial disease on the background of high-intensity statins. They are randomized to inclisiran versus placebo, and the study is designed to go on for a minimum of 3 years, and we're looking at 6-year events to determine whether you can reduce mortality, an important endpoint for any intervention in cardiovascular care. So we're actively recruiting patients. We're trying to recruit equal numbers of women versus men, people of different races, ethnicities, and we do a great job here at Mount Sinai in terms of representing those who are less represented in most clinical trials. So if you have any patients that fulfill those criteria, we're eager to help them get involved in this trial. What about the effects of inclisiran on plaque? We're involved in Victorian plaque study, which is a CT angiographic study that'll be conducted in individuals who have subclinical atherosclerosis. So more in terms of in between primary and secondary prevention, a 24-month study. I mentioned gene editing. We're going to learn on November 5th the phase 1 study results that will be presented by Verve. And this is a very exciting approach, very selective therapy using a GalNAc moiety, go right to the liver, and then you inhibit, PCSK9 through, knocking out those, base pairs. And as I mentioned, they'll be going into phase 2. Will be involved in those studies come 2023. They also have an angiopoietin-like 3 target, which they've sought my guidance for the design of those clinical trials. I now want to pivot to angiopoietin-like 3 because you probably haven't heard about this pathway nearly in as much detail as the PCSK9 inhibitors. Angiopoietin-like 3, again, discovered from genomic medicine, was shown when you have loss of function in 2 large Mendelian randomization studies that those individuals had lower LDL cholesterol, lower HDL cholesterol, and lower triglycerides. And you say, wait, lower HDL cholesterol, that's not a good thing. But it's due to interruption of endothelial lipase, which is not associated with increased events, as Seth Catherine reported in the Lancet, that caused the whole field to get up in arms. How could he have a lower HDL cholesterol, not higher event rate? But importantly, in the Discover EHR trial, there was a 40% lower odds ratio of coronary artery disease. And those results were confirmed in another Mendelian randomization study. So lower LDL cholesterol, lower triglycerides, but lower HDL cholesterol and lower rates of coronary artery disease. How does angiopoietin-like 3 work? It inhibits the activity of lipoprotein lipase and endothelial lipase. What is lipoprotein lipase? It's the key enzyme that hydrolyzes triglycerides. So individuals who have high angiopoietin-like 3 have higher triglycerides, lower HDL cholesterol. If you block it, triglycerides fall, the HDL cholesterol can actually go up from where it was before. And we've studied the effects of this agent in patients with severe hypertriglyceridemia in the multiple thousands who have had a pancreatitis. And that data was presented last year, American College of Cardiology, and I'm happy to report that we finally have a decision in Nature Medicine that the paper has been accepted. But I'm going to focus on the LDL cholesterol effect. That's endothelial lipase, which you probably haven't heard too much about. And endothelial lipase remodels the very low density lipoprotein in the liver. Through hydrolysis, you get the large nascent VLDL becomes smaller, and the smaller VLDL gets converted to a larger LDL, more effectively cleared by the LDL receptors. But there's another mechanism whereby the LDL is cleared with inhibitors of angiopoietin-like 3, yet undefined. So through the endothelial lipase effect, you have a decrease in LDL cholesterol. Well, show me the data. This is the ELLIPSE HoFH trial, and I was the second global lead enroller in this trial, and maybe some of your patients agreed to participate in the trial. This is a study of people with HoFH that was diagnosed genetically or clinically based on 2 parents with HeFH or individuals who, as children, had cholesterols over 500 milligram per deciliter and tendon xanthomas, an extremely high-risk population. They were on a lot of therapies. They may have been on LDL apheresis and maybe 5 other medications. They were randomized 2-to-1 to receive evinacumab, 15 milligram per kilogram IV versus matching placebo, and treated for 24 weeks. And then there was a 24-week open label extension. The average LDL cholesterol on all those therapies, including LDL apheresis in many of them, was 246 to 259 milligram per deciliter, extremely high. And it's no surprise that many of these individuals with HoFH die as children or die as young as adults. It's a very difficult condition to treat. And the risk is related to the residual LDL receptor activity. Recognize there's 1,300 mutations. Some have more loss of function than others. And the null mutation patient is extremely difficult to treat and extremely high risk. The primary endpoint was change in LDL cholesterol, placebo-corrected differences, 49%. But most importantly, in individuals who had null receptors and LDL receptor activity less than 2%, the most difficult patients to treat, evinacumab reduced LDL cholesterol the same as individuals that had residual LDLR activity. This is an absolute amazing breakthrough for those individuals who are at the highest risk, the ones that often die as children. So we're very proud of those results. The therapy was very well tolerated. Some nasopharyngitis, flu-like symptoms, which can occur with monoclonal antibodies, but extremely well tolerated. Now you would say HoFH. Nobody can achieve the target. Well, with evinacumab, some people could. If we look at an LDL cholesterol goal less than 100 milligram per deciliter, half achieved the target, less than 70 milligram per deciliter, 31.7%. You say maybe that's not enough, but look where they started, almost as high as 260 milligram per deciliter. And if you look at individuals who have atherosclerotic vascular disease, achieving an LDL cholesterol goal less than 70 achieved by 37.5%, and even the new, more aggressive LDL cholesterol goal, less than 55, achieved by 31%. What about LDL apheresis? It's an option. It's a viable option, but it requires the patients to go to an LDL apheresis center, of which there are not many, go for every 2 weeks, treat for 3 to 4 hours. Some patients don't have too large veins and they require fistulas, just like if you're undergoing dialysis. And if you happen to be on evinacumab in this trial, your need for LDL apheresis decreased and the eligibility for LDL apheresis decreased. So you think about quality of life with some of these new therapies. So how do we put it all together for HoFH? This was an algorithm from an invited paper by the Journal of Lipid Research. You start with maximum tolerated high-intensity statins. Because of the decreased LDLR activity, not everybody responds. In HoFH patients with null activity get 8%. Is it worth it to be on atorvastatin 80 or Rasuva 40 for 8%? Maybe not. You'll add ezetimibe. You'll go to a PCSK9, which are 50% less effective in HoFH patients. And then you can consider evinacumab, lomidopide, LDL apheresis, or sometimes you need them all. And so as the new therapies become available, we develop algorithms based on the science. What about the more common condition, patients with heterozygous FH? In this real-world study by Realitis, individuals who are on statins, ezetimibe, and they were all on a PCSK9 inhibitor, you can see that only 44.8% actually achieved their LDL cholesterol goal in Europe of less than 55 milligram per deciliter. And if they have statin muscle intolerance, it's only 26%. We need new therapies for those individuals. It's not a rare condition. 1 in 311 worldwide, more common in people from French Quebec, Lebanon, South Africa, where maybe as common as 1 in 70. And you're going to encounter those patients. If you see patients with coronary disease, which we all do, it's present in about 1 in 21. If you see patients with LDL cholesterol is greater than or equal to 190 milligram per deciliter, it's present in 1 in 11. You see these patients. You may not recognize them because you may not be thinking about a genetic disorder, but it's important to think about a genetic disorder. Why? If you have a genetic disorder versus an acquired high cholesterol, your risk for a future cardiovascular event increases 22-fold versus having high LDL cholesterol over 190 increased 9-fold. 9-fold still high, but if you have FH and a high LDL cholesterol, it's 3.25 times even higher. So that's why we think about genetics. And also, we want to help the family members. We want to help the children to prevent them having a cardiovascular event. That's why we think about genetics. I had the pleasure of being the global lead and the lead on this study of refractory HeFH, just showing you the intravenous arm. We had a subcutaneous arm, evinacumab, dose-ranging study, IV treatment versus placebo. The change in LDL cholesterol, with higher doses was as great as 56%. And the therapy was well tolerated. And again, how would we think about it? The drug is not indicated for HeFH at this point, but we would think about this in people with refractory hypercholesterolemia not responding to high-intensity statins or maximum tolerated statin, ezetimibe, and a PCSK9. What about other therapies other than monoclonal antibodies? We have an antisense oligonucleotide, which is the basis of the Translate TIMI 70 trial. Individuals who had high non-HDL cholesterol is the primary efficacy endpoint of this trial. The LDL cholesterol was in the 80s, triglycerides in the 200s. This trial was accompanied by reductions in non-HDL cholesterol in the 20 to 28% range. In terms of LDL cholesterol, as shown in the gray, anywhere from 10 to maybe 16%, far less than the 50% that we reported with the monoclonal antibodies. But this therapy was terminated from future development because there was a dose-dependent increase in transaminases, as you can see, up to 39% at the higher dose. And there was a 1.76-fold increase in hepatic fat. So based on those results, that therapy was terminated, a program by Axia and Pfizer. But does that mean that there's no future for angiopoietin-like 3? Well, stay tuned for my presentation coming up on November 7th. We took a different approach, small interfering RNA using Arrowhead's compound. This is a parallel-armed dose ranging study where we're evaluating individuals with elevated LDL cholesterols on maximum tolerated therapy, elevated triglycerides between 100 and 499 milligram per deciliter. So when I present these data, you're going to look at the efficacy, you're going to look at the safety, including the data on transaminases and hepatic fat. Okay? We're also looking at this Arrowhead compound in patients with homozygous FH, and we've randomized 3 individuals into that trial. Are we going to see efficacy in line with what we reported in the Lipids HoFH, something less? And if it's something less, does it make a difference in terms of lowering the LDL cholesterol in these high-risk individuals? But the dosing is once every 12 weeks in this study, so very different than coming to the infusion center every month with the monoclonal. In the last part, I'm going to pivot to lipoprotein A. And I love this particle because it's complicated. And there's a lot of challenges and a lot to be discovered. And I'm very proud to say that through philanthropic support from my patients, we're going to be presenting a novel mechanism of action where lipoprotein A triggers inflammation, triggers blood clotting, unrecognized pathway, and that presentation was identified as one of the top 5 basic science abstracts for the American Heart Association, and I'll be presenting that data as a special session on Sunday morning at the American Heart Association. But meanwhile, what do we know? We know that LPA increases immune activation, platelet activation that's under genetic control, destabilizes plaque, contributes to atherogenesis. What about lipoprotein A related risk? If you're on a statin, does it make a difference? Yes, it does. This is the pooled analysis from Willett that shows that if you're on a statin, LPA increases the risk by 1.48-fold, multivariate adjustment 1.47-fold. It's an important source of residual risk. And how do we approach this? But before I talk about that, I just want to share some of our other data from the REGARD study, a large 30,000 prospective study. And what we reported is the higher the LPA, the greater the risk of coronary heart disease events, both in whites and blacks. But look, the distribution is very different. It's skewed to the left in whites versus more normally distributed in blacks. So in order to evaluate the racial differences, we did a quartile analysis. We also reported that the association between LPA and coronary heart disease is significant, whereas for stroke, it's not for both for whites and blacks. And so other factors influence stroke risk more than LPA. So if you design a trial, and you'll see this in a new trial design, you really want to focus on people with coronary heart disease predominantly. It doesn't mean that you don't have a 5-point MACE or a 3-point MACE, but coronary disease is where the association is greater. Now, PCSK9 inhibitors do lower LPA modestly, anywhere from 0 to 35%, average about 25%. And in the Fourier trial, the large outcome study with evolocumab, those with a high LPA have higher event rates. And if you, as you can see here, and if you if they're treated with evolocumab, the absolute benefit in people with high LPA is greater. Okay, so that may be one approach. What about a selective therapy, pelacarsen, which is antisense, and this shows a dose-dependent reduction in LPA. Published in the New England Journal, we participated in that trial, and it's a subject of the phase 3 trial that we're also participating in, known as Horizon. Patients with major adverse cardiovascular events, MI, stroke, symptomatic PAD, lipid-lowering therapy, randomized to pelacarsen versus placebo, designed to last for 4 years, and the primary endpoint is time to expanded MACE. Olpasiran is an RNA inhibitor, and this is the phase 1 data that was just published in Nature Medicine. This is a very busy slide, but the LPA levels, here, were quite high, and you can see that olpasiran resulted in a dose-dependent reduction in LPA levels approaching in the 90%. This is the phase 2 study that has been completed. It'll also be presented as a late breaker at the American Heart Association. We were the global lead in this study, and will be represented in the publication that'll appear simultaneously at the time of this on November 6th. It's a dose-ranging study with this treatment, and we'll tell you more in 2023 about the phase 3 trial design. Silence Therapeutics also has an RNA inhibitor that's also effective in lowering LPA by as much as about 96%. So to summarize, what an exciting time for the field of clinical lipidology. We can almost do anything with these new therapies, at least lipids that are synthesized at the level of the liver, understanding pathways because of genomic medicine. Who would have ever thought the Human Genome Project would have resulted in so many cures or so many treatments for our patients? A great time. We focus on LDL cholesterol, but remember that there's other factors that include lipoprotein A, remnant cholesterol, the unknown, the HDL particle, and how do we target those therapies to further reduce cardiovascular event. So I'm very happy that in our center we're involved in almost all the trials. We enroll consistently the most racially and ethnically diverse population. It's still not enough. We need to learn more about other races and ethnicities, no doubt about it, but we're doing our part in terms of the global contribution in that area. Thank you very much for the invitation, a great honor.